That is Dichotomy of Insulin, Innovation and Adoption. And as a speaker, we have none other than Dr. Hridish Narayan Chakravarti, a very renowned endocrinologist attached to Narayana Hospital, Howrah. And as a chairperson, we have Dr. R.L. Joshi, a renowned cardiologist, and Dr. Shottam Chakravarti, a famous endocrinologist who has been attached to HDS since the beginning. So I would like to request both the chairperson and the speaker, and please introduce our speaker. Dr. R.L. Joshi, sir.
Hello. I think we are running short of time, so Dr. Hridish Chakravarti needs no introduction. Basically, he was the Fungshuk Wangdu of our batch as far as DM is concerned, the last bencher with best academic results. So I do not go much more further, and I should ask Hridish da to start his deliberation.
So, thank you. Shottam has given a wonderful introduction I couldn't even fathom. So, he has really enthused me, but because we are running short of time, I would cut down to about 20 minutes instead of 30 minutes so that I am not standing between you and the lunch, because the other room is already completed, I believe. So, the discussion starts. The topic is the dichotomy of insulin innovation and adoption in current era. Now, I always start with a disclaimer that medical science is always an ever-changing field. So, whatever I am saying is valid for today's date only, because kal kisne dekha hai. And I always carry two thank you slides with me. The last one is obviously at the last. The first one obviously goes out to the organizers and the sponsors, because they deemed me fit to speak on this particular topic. Now, agenda in short would be the issues of delayed insulinization, hurdles and solutions, the physician and patient barriers, the 100 years of evolution, and the conclusion. Now, this is obvious that diabetic prevalence is increasing worldwide due to various reasons, and especially in our part of the world, we have moved away from our traditional way of lifestyle, traditional way of eating, and we have just taken the westernized culture, which has caused huge rise in non-communicable diseases, while we have been able to control the infectious diseases. If you look at the burden of diabetes in India, about 11% of India's population today is diabetic. Even one worrisome is that 15% could be pre-diabetic. So, a huge flux of people would move from the non-diabetic to the diabetic range. They may be now pre-diabetic, but as they are not knowing, so I put it as non-diabetic. So, in the coming era, maybe the burden on the healthcare system would be much more than what we are expecting today. Coming to the extent of insulinization in India, you can see that about 31.3% people with diabetes are being managed with insulin. Now, this line can be interpreted in two ways. Some people may say, well, because we have so many oral agents, so insulin is not being required. The other side of the story, the flop side of the story, is that actually people are needing insulin, but because the patients are not wanting to take and the doctors are also deterring to write the prescription of insulin, actually we are delaying the insulinization procedure. So, that is exactly reflected on the right side of the panel, that 50% of patients with uncontrolled type 2 diabetes are actually delaying the insulin therapy. Now, just a hypothetical case, suppose a 55-year-old male having type 2 diabetes for about a decade, having a fasting in the range of 190, PP in the range of 246, HbA1c is a horrible figure of 9, and he is getting the full dose of metformin, the gliptin, teneligliptin 20, and also full dose of empagliflozin. So, what do we do now? The issue is he is already on 3 anti-diabetic oral agents. Now, it is seen that addition of a subsequent oral anti-diabetic agent doesn't offer benefit beyond 3 drugs. That means you have given one drug, fine, the sugar is not controlled after some years, you add on another drug, fine, you add on a third drug, but if you go on adding, there is a plateau or ceiling effect beyond which you cannot accrue extra benefit. That is what is happening actually after 3 oral agents. I found this very interesting article when I was doing in DM in SSKM 2013. Ralph DiFranzo had written that we doctors actually treat to fail. not to succeed. That means the patient has come with high HbA1c or sugars, we add a medicine, wait for things to go haywire, again add another medicine, then go for the third one. So every time we react is actually when the sugars are high. We do not take steps proactively, we take steps reactively. So that is exactly valid for diabetic management as far as the oral agents and insulin are concerned in today's date. Now obviously poor blood glucose will lead to increased risk of developing various complications. Many people say ki we will give SGLT2 inhibitors, GLP-1 receptor agonists because they give so many collateral benefits to the patient. But first thing we have to remember, we have to control the sugars. We can extrapolate this from the way back from the UKPDA study that every 1% reduction that we achieve in the HbA1c can bring down AMI, foot ulcers, amputations, heart attacks, strokes by so many percentages. So obviously we have to remember that the cornerstone of therapy is sugar control. If we do not do that and just claim we will give SGLT2 inhibitors, GLP-1 receptor agonists to give some benefits, I don't think that will translate into any clinical good things. Coming to the second part, the physician and patient barriers. This is very important in today's date. First, I will talk of the physician related problems. The first thing I will say is the needle comes in between you and your patient. Anybody, even if it is me, asked to prick 4 times a day, I would also deter, I would say, no, I don't want to take insulin, give me something which I can pop a pill. So that's one important issue. Now coming to the physician barriers, not only money, time and manpower also matters. So 74% of the healthcare professionals do not give more than 10 minutes for consulting a patient. This is very true, and it may be even less in a periphery or a government setup who are seeing 600 patients per day. And manpower obviously, because when you insulinize somebody, you need to explain certain things which we may not be able to do in our busy OPD. So we need to incorporate certain other third-party people who will be able to demonstrate these things, explain those things, and to remove the anxiety of the patients, what questions they may have in their mind. So manpower is also a problem which we have when we insulinize. Physician barriers may also be regarding the hypoglycemia. Obviously, patients are also now aware and doctors are also aware. If my patient develops hypoglycemia, he will run to another doctor. So that part is obviously there because patients definitely do doctor hopping. Weight gain is another concern both on the part of the patient as well as the doctor, and also poor quality of life. The patient feels caged. Like he was free, he becomes caged that he has to take 4 pricks per day. Now, complexities are also there, like suboptimal knowledge on guidelines, changing the targets, what newer therapies have come in. So we need to incorporate nurses, pharmacists, diabetes educators. They will go a long way in actually explaining the patients and alleviating their anxieties from their mind. And lastly, newer insulins which are now in the market are having less hypoglycemia, less weight gain, and can definitely offer a better quality of life. So solutions may be self-education, CMEs, hand-on workshops, and all these things which we do. Now coming to the patient-related problems. Psychological insulin resistance is one of the most important things that deter or actually defer insulin therapy. The patient thinks this as a personal failure. Like in COPD, people think inhaler is the last stage, and diabetes people think insulin is the last stage. Actually, it should be just the opposite. So this is actually thought that when the doctor is writing an insulin prescription, as if he is punishing me that because I could not control my blood sugars. So this is a personal failure that is perceived by the patient. And they also think positive gain is not expected out of this. Cost concerns are also there. So this ultimately leads to many cascading effects, that the patient sometimes self-reduces the dose, omits few doses in the fear of hypoglycemia, reducing cost, etc. That can lead to complications. I will just skip these slides. Just important thing is that we have to start the insulin conversations shortly after diagnosis. And if you think you have a patient who has been diabetic for 15-20 years, if you write insulin today and if you explain today, you are in a soup. So just think of that fast bowler. He gains momentum by running certain distance and then only he throws the ball. So similarly, if you think that today the sugars are going around 200, 300, maybe 1 month down the line you will actually write the prescription, but initiate the discussion today. That actually helps a lot in alleviating the anxieties of the patient. So early initiation of discussion is very important rather than early initiation of insulin actually on the prescription. Now there are various other problems like lipohypertrophies. These actually are lumpy things which are present in the subcutaneous space. The patient goes on injecting in the same space, doesn't change the needles. So these can be some problems in the process. Lipoatrophy also is there. Some excavating lesions can be seen, and these are very disfiguring to the patient as well. Now this is a real time. I just took this photo few weeks back from my patient. This is insulin allergy. If analog insulin was given and the patient was injecting on the right side only, I changed the brand and then this disappeared, and this is a horrible thing. I scolded my patient, what did you do? But actually I knew that there was an act of omission from my part as well, because he was a right-handed person. He was just injecting on the left side repeatedly. He was not even utilizing the right side, and he was not changing the needles as well. So this actually resulted in this thing. So I actually blamed myself that maybe I did not tell all these things, that you have to raise with a skin pinch, you have to rotate the sides, these are the places where you need to inject, and you have to rotate not only in the same place but also in the quadrants when you are using in the abdomen. Don't inject in the same place every time. And maybe I didn't give all these grids. These grids are now available. These are papers. Just hold it there and just you can push the insulin there. And coming to the new innovations that we have now, many patients say, I will not be able to use the pen, give me the vial only. I just explained, do you have this fat TV at your home still? You have moved on to the slim TV, then why don't you accept technology? Because that will actually become easier. But for that you have to demonstrate and explain, otherwise it will be of no use. And we also need to tell that this is a common problem in our society, that these syringes are not the same. Even our sisters in the wards and even the chemist shops, they also sometimes just mix up them. We need to understand that the color coding and the numerical nomenclature on the syringes are different. One is code till 40, one is till 100. So U100 should be used with U100 thing, that means vial and syringe, and U40 should be used with U40. We should not mix. It can lead to hypo or hyperglycemia. We also tell some patients, like some patients will undergo short surgery. Like my friend Niloy is here. Suppose a spine surgery will be held. The patient is on, say, oral agents well controlled. He will be admitted for 1 week. Then what happens? We will give a quick pen or a flex pen only. I will tell the patient that this is not a lifelong insulinization. We will give you a pen which you can just use for 1 week or 2 weeks. You just throw it away. When it is done, you can go back to your oral agents. So these examples actually help to explain. And also regarding the needle changes, just see after 6 pricks, this is the situation of the needle. So it is just like that we read in forensic medicine that harakiri. That means you prick something and then bring it out, the entire intestine comes out. So similarly, this is the reason why the damage to the subcutaneous space occurs. So you should not be reusing the needle, and ideally a needle should be used only once. But in our setup, resource constraint, we can say maybe 2 to 3 times we can use it. So all these factors can potentially upset the glycemic control. And there are many a slip between the cup and the lip, what I said. We just write in a busy OPD a prescription of insulin. But there are so many factors behind it which needs to be kept in mind. And the blame comes on insulin. আপনি ইনসুলিন দিয়েছেন, তারপর থেকে আমার সুগার আর কমেনি, আগে আমি ভালো ছিলাম। আর আমার পিস্তত ভাইয়ের মাস্তত ভাই insulin নেওয়ার পরেই মরে গেছে। So these things happen because of these problems. We do not explain them. And I always draw the analogy of insulinization with marriage. So when people are getting married, only 2 individuals are involved. So apart from the dressing table, the cord, the washing machine and the fridge and the jewelry, also in-laws are there, responsibilities and duties are there. So when you insulinize a patient, it is not a marriage between the patient and the insulin pen. Basically you need to consider all the gadgets, the glucometer, the strips, the pens, the vials, the needles. So the patient thinks that I am totally caged somewhere. My life is totally gone horrible when the doctor has started insulin. So this part has to be kept in mind. The psychological insulin resistance actually stems from here. And lastly, 100 years we have reached of insulin discovery. So we have moved a lot. Evolution of basal insulins. When we were students, we used to talk something like this. We only had the 2 middle peaks there, short acting and intermediate acting. Now we have added on the right side long acting insulins, Detamir, Glargine U100, then we had Glargine U300, now we have Degludec from Novo Nordisk, and maybe we'll have something more in the coming times. And on the left hand of the spectrum, we have rapid acting or short acting insulins, which act very fast, especially in type 1 diabetic children and elderly patients who are very moody. They do not want to eat. Suppose the daughter-in-law has made khichdi for him. He said, no, I will not take this. But he has already taken the insulin. Now what happens? There is a risk of hypoglycemia. Even for children this happens, type 1 diabetic, who are very much revolutionary, adamant, they don't listen to their mothers what they have prepared. So the mother has given the insulin and then the child says, no, I will not eat now. So hypoglycemia is going to occur. The best thing about this rapid acting insulin is that the mother has ensured that the food has gone down the esophagus and then she can give the insulin. So these are innovations which we have made in the current time. So this is important. And insulin Degludec definitely has shown consistently proven hypoglycemia benefit, lower variability, and a lot of time adjustments can be done. Like somebody was talking about somebody has gone to a marriage party, he can come back and take the insulin. Or somebody is having a crossing time zones in an aircraft, he can land and then take the insulin. So these are some benefits which we can have. Evolution of premix insulin has also occurred. I have just noted down in short that these are the various permutation combinations that we have in the market. I heard from some of my teachers that maybe 30 years back, there were insulins which were also 10-90, 20-80 ratio, but now we have only 25-75 and 30-70 ratios. So this is how we have moved from syringes to pens to pumps to artificial pancreas. And patients and physicians identify higher frequency of insulin injections as a burden. So somebody told that you will take 4 injections per day, and somebody being told that you will give only 1 injection per day, obviously the second category of patient will be happier with me. And we see that 33% of patients omit their dose and become non-adherent if you give many doses. I have many children of type 1 diabetes who say, ki, because I go to school, I cannot take the afternoon or the lunch dose. So they just go on skipping it, because they say, I can't do that, I don't have a specific room there, I have to go to the washroom to inject myself, it is unhealthy, and other people make fun of me. So these are real issues which we face. So summarily, we say that it is time to bridge the insulin inertia. Poorly controlled diabetes leads to increased risk of developing micro and macrovascular complications, and frequent insulin injections are burdensome and cumbersome and inconvenient, contributing to therapeutic inertia and poor treatment adherence. And people with diabetes and physicians prefer fewer injections to reach their glycemic goals. So obviously there is a need for insulin regimens that are less restrictive and burdensome. And future may be quite bright, because this is how we moved in the last 100 years. Maybe in the next 1.5 years, we will get some more magical insulins. We have to wait for that. And lastly, in the last slide, I will bring you back to the topic I had, the dichotomy of insulin innovation and adoption. So what is dichotomy? Dichotomy means contrast. That means war and peace, love and hate, something like that. So maybe innovation and adoption always do not go hand in hand. That is exactly where we need to bridge it. I'll stop with one example. We started with these phones. Now we shifted to these phones. 10 years back, when the smartphone was launched, to my uncle who was 83 years old at that time, I handed over this smartphone. I said, use this. He just moved it for some moment and then threw it away. Why? Because the innovation is good, but I could not get it adopted to him. I did not give the time. Similarly is with the insulin devices as well. If you give a pen, complex pen, and you don't demonstrate, he will obviously say, amar vial ebong syringe bhalo chilo. So that's the thing we need to incorporate in our daily practice. So I always end my presentation with a social message. There is only exactly 1 month countdown. Today is 14th October. Next month, what it is? It is obviously World Diabetes Day. So till that, we should actually try in the next 1 month to educate our patients so that they actually adopt and adapt to the new innovations that we have. So let us ensure adoption of insulin innovations in a proper way. Thank you.
Hello. So I presume why I gave that introduction about Hridish after the beautiful lecture, and I think.
Yes, he has done it explained it in a very nice way. What are the obstacles, and why patient hesitate to take insulin, and why doctors hesitate to write, because the number of pricks and all other matters to be explained them that is also very important. This is only not prescribing, but make the things with the help of dietitian and educator, and we too have to give some time to the patient to explain.
Anyone has any queries? Explained it all. Thank you.
Thank you. Thank you.
Let's end this session.
Thank you, sir. It's time to felicitate our speaker. I would like to request our chairperson to please felicitate him. I'd like to request Dr. Shomnath Nashkar to please come and felicitate our chairperson. Thank you all. Please join us at the lobby area. A delicious lunch is waiting all for you.